My name is Arosha Weerakoon, and today I'd like to talk about or ask the question, are we optimizing care or automating inequity related to artificial intelligence in Australian healthcare? I am from the University of Queensland School of Dentistry. I am a practicing dentist, and I also teach the dental students courses on population oral health. So, to begin with, I would like to ask a question. Uh, why are we considering AI in healthcare and potentially in population health as well? Well, one of the things, or some of the things that we are facing, particularly when we are trying to help so many people, is that there's increasingly workforce shortages and the increases in number of people that require our assistance, as well as the number of data sets that are quite challenging sometimes to work with. And of course, we're looking for improved efficiency. And this is where generative AI it has the potential to help us improve our diagnostics, not just potentially to improve the diagnosis, but also help it happen a lot faster. And the idea, of course, is it can improve the pace or the rapidity of how we diagnose things or discover, say, a disease outbreaks by helping those who enforce these changes to support their decisions, but also remove, in some ways, that burden of administration to help automate things. And there is a notion that we potentially could also personalize care. So I asked this question within the Australian context, which is where I live and work. And one of the things that really bugged me was I wasn't sure how it worked within our landscape. And this prompted myself and two other academics, one who's Tonia Gerdes, who is one of the four dentists that works for the Australian Health Practitioner Regulation Agency, to review what was in the space of artificial intelligence in healthcare, but then try to fit that within the context of how we are governed. So some of the things that we discovered really was that in its availability as it is now, we're using it for X-rays, so interpreting images and X-rays, and it's helping the detection of pathology, particularly within the context of Australia, where people are so remote in some instances from actual health services. Pathology detection is really important because then it allows for people to still live and work in the areas that they reside in, but receive care and support from a distance. In terms of the population level as well, it can help disease prediction models. So we can, and this happened with COVID outbreaks as well, in particular, where there was this increased capacity to help predict diseases, but also for the capacity to deliver telehealth and the ability for practitioners or even, say, epidemiologists or health service providers to monitor what is happening from a distance rather than having to actually be on ground to understand the needs of the people. So part of our scoping review, we essentially reviewed the literature from 2016 to 2024. We looked at these databases, and after reading quite a few studies, We ended up including 31. And our focus was really to look at how we're using AI in healthcare, how these implications fit within the Australian context. But probably the significant thing that we were interested in was what are the rules behind our governance and accountability. So to give you a little bit of context, what happens with healthcare in general, whether it's public health in terms of interventions or health promotion, as well as clinical care, what we do for our patients sits within quite a big, robust framework in some ways. And so there are things like the legislation where all health or a lot of people have rights through the Privacy Act, the Civil Liability Act, the Therapeutics Goods Administration also administer or they regulate a software that has the capacity to help make decisions about people's healthcare. And then, of course, there are multiple stakeholders from various healthcare areas, as well as the other agencies that regulate how we operate and how we work. And then we have this shared code of conduct that embeds the ethical use of anything or applications of anything towards our healthcare. One of the issues that we discovered was that there is a black box problem, and what a black box problem essentially is you put in the data, the algorithm will work its, we'll call it magic, and then suddenly you have the solution. In real time human decision making, often our decision making is quite transparent. So you can ask the person or the leader and say, well, how did you come to this or reach this solution? And then there would be some sort of explanation. And unfortunately, that becomes a bit opaque when it comes to trying to understand how Gen AI creates these outputs. And that means that there's less transparency of understanding how it reached that decision. So you can't actually intercept at some point to determine whether it's incorrect or not, or change its trajectory, which then creates this issue of, well, who is ultimately responsible or what is ultimately responsible for the outcome of this output? Would it be the person who decides to enforce change, or is it the software developer or the person who perhaps trained the algorithm, or even the people who collected the data set and analyzed it and cleaned it and provided it to train the algorithm? And this is something that is creates sort of a gray area when we're looking at that stage. Within the Australian healthcare context, that responsibility at the moment solely lies on the practitioner. It is, and the software is considered a tool rather than a sort of final outcome. Some things that really concerned me, and this is why I'm here and I want to talk about this, is the fact that AI has the ability really to amplify disparities, particularly those that are already in existence. And part of that is that often it will miss minority populations or underrepresented populations. And that means that some of the generalized information may not apply to everybody in the population. And of course, we're looking at digital technologies. So a country such as Australia, where a lot of people have equal or equitable access to digital technologies, this sort of programs and so on are easier to actually incorporate. But when we start looking at countries, say, such as Sri Lanka, where we have this disparity in access to healthcare, access to technology and the internet and Wi-Fi and computers, this causes a lot of issues. And of course, we start challenging the people who encounter barriers to good health through the effects of structural social determinants of health. In Australia, one of the things that we have and we understand, and the Australian Institute for Health and Welfare has identified are a list of priority populations. And in our case, we have our First Nations people, the Aboriginal and Torres Strait Islander people, those who come from a low socioeconomic background, those who suffer from mental illness, who identify as LGBTQI, those with disability, the people living in rural, regional, and remote areas, and culturally and linguistically diverse people. Ironically, I'm a Sri Lankan born person. If had I lived in Sri Lanka, I would be part of the majority. But living in Australia, I am a culturally and linguistically diverse person, and I'm part of the priority populations that the government considers to be underserved. And often it's these sort of populations, and every nation will have their groups that have or experience greater disparities compared to others that usually require more social support and interventions and assistance. So the recommendations that came out of this paper is that really some of the challenges that many nations are going to face or are facing is that you really need clear governance frameworks. And the reason that I wanted to talk about this topic was because I wanted to see or understand what other presenters at this conference, what sort of backgrounds do they come from, or do you come from? And what sort of frameworks do you know of that may be in place to help protect people? And if they don't exist, perhaps to consider being part of that change. The significance, of course, of understanding how much diversity we need in our training sets. I cannot explain or express how significant this is, because we don't want to perpetuate those disparities. And it's important to make the decision-making system as transparent as possible so that if there is that requirement for accountability, then you can explain, well, this is how we reach this. But some of the things that were really highlighted in these systems was the need to not only educate our clinicians, but users and our patients, or the people that are involved in deploying these algorithms and enforcing these, I guess, recommendations or outputs, is to understand what the limitations are and to develop these critical skills that are essential. And also to help protect the privacy of our most vulnerable, because we don't want to see their information or data being used against them or to exclude them into the future from the protective effects that hopefully still exist, because there's a lot of room for discrimination. And with that, I would like to conclude my presentation. Uh, I'd like you to consider the fact that we do have the opportunity to transform our healthcare, but innovation must be balanced with our ethics, understanding of governance, particularly within your framework, and also to use it with equity in mind. So the key question I would like to leave you with is, are we optimizing care or automating inequity? And I would like to think that we will shift more towards the former than head towards the latter. Thank you. Uh, I welcome any questions or correspondence through my email, and I look forward to connecting with those who might be interested in moving forward or taking this on, because I'm always open to collaboration. And my name is Dr. Arosha Weerakoon from the University of Queensland in Australia. Thank you.